great to see people in seats, and we get to meet face to face again. So pleased that you're here, and I believe we also have some people still participating by in-house TV, and that's great too. I think I know just about everybody in here. I'm Dr. Wright, Larry Wright. We're all representing the UAMS clinic here at Butterfield Trail, as you probably know. And for a while for a year or so, we were doing these presentations twice a month, with the alternate second time a month being more what I called an open mic. Just bring any questions you have on any topic to do with health and aging. And that worked out really well, but then it didn't work out so well when it was just being piped out on TV, so we hadn't done that for a while. But now that we're meeting again face to face, maybe we'll kick that up. But what we are doing, and we're doing before too, is a specified topic. And today, as you've probably heard, the topic is dizziness. Just as a reminder, because we haven't met in a while and I don't know who's listening out there and who isn't, I'll explain who we are, what contingent from UAMS is here all the time. So I'm here all the time, pretty much every day. Tuesday right now, we don't have a physician here, but that's going to change pretty soon as well. So we will have 5-day-a-week clinic with a physician, probably starting at least in 2 months, if not sooner. Glad to say that. But I'm here regularly anytime the clinic's open, and I'm virtually always accompanied by 2 resident physicians. So these 2 who are presenting today, 2 doctors who I'll introduce, are doctors who received their medical degrees sometime in the last few years and are now participating in a 3-year training program, residency training program in internal medicine, which after 3 years they become full-fledged internist, internal medicine specialists, some of whom will go on to do internal medicine specialty work and do a fellowship, and some who will go into a more general practice straight out of residency. Either a general sort of, I'm so sorry, I need to turn this off. Sorry. Either a general primary care sort of practice, or one of the very popular alternatives for people who want to practice general internal medicine is hospital medicine. And if you've been in the hospital, if you've been a patient in the hospital or had someone in the hospital in recent years, they likely were under the care of a hospitalist. So that's a specialty, hospital medicine, that has grown up in the last decade and a half, and it's well established now. So that won't be going away. So a lot of these doctors go into hospital medicine or general internal medicine, or they pick a specialty. So that's who's in the clinic every day. We also go over to healthcare and take care of patients there as well. In addition to resident doctors doing their residency training, we're starting just this month for the first time to have a medical student here with us. Not every month, but many months going forward. So this is the first time, and the test case right here is Charles Horton. And the future Dr. Horton, he's in his 3rd year, just about to finish his 3rd year of medical school, so he has 1 more year before he gets his MD. So he's in the UAMS medical school here in Northwest Arkansas for his last 2 years. He's from Berryville, Arkansas. Now, we say Berryville over here, but where he comes from, they say Barville. Am I right? Yeah. It's 1 syllable to start the word off. But he is from a family of physicians. His father's a family physician in Berryville. His sister's a family physician in Berryville. And he will be a family physician in Berryville. So very proud of him. And they sent us the sharpest guy in the class the first time out. He denies it, but I know it's true. So he won't be presenting today, but I think I'm going to let him take the phone calls that might come in. So with that, let me say to those who are watching on TV that if you have a question, you could call in your question to this phone number. He's got the phone, and the number is 479-200-9259. 200-9259, and he would relay the question on. I hope everybody in the room here will ask a question in person. So with that, let me introduce the program. I told you it was on dizziness. I want to tell you about these two physicians. Some of you may recognize him from, it's his second tour out here. But Dr. Andela, it's her first time here. So Mamwa Andela is going to be presenting first, is a first-year resident, but she's been in healthcare for a very long time. Now, she grew up in Cameroon. I'd hate to have to go to the map of Africa and find that country, but I know roughly where it is in West Africa. And at age 15, immigrated to the U.S., am I right, 15? With her family, and has lived in Chicago and more recently in Kansas City. And for 20 years was a nurse, 12 of which she was nurse case manager at KU Medical Center in Kansas City, which is a very important job in any healthcare center. So you have to know a lot to be a case manager there. And then she went to medical school. So she comes very well prepared in healthcare and in medicine. A lot of doctors think they know everything nurses know. No, we don't really know anything nurses know. We don't know any nursing, but she does. She knows nursing and medicine, and that's a really special set of understandings. So then Rikov, goes by Rico Vasanwala. Almost seems like a native of Northwest Arkansas now because he's lived in Rogers for quite a number of years, but from Chicago, really, and immigrated down this way. And before he went to medical school, before he started our residency program, was an assistant physician working in primary care practice in Southwest Missouri. But now he's finishing his second year of residency training. So with that introduction, I think you'll find this very interesting, the topic, and I'm glad you're here, and we'll talk more after they educate us.
Good afternoon, everyone. It's too tall. Hello. Good afternoon, ladies and gentlemen. I would like to thank all of you for being here today and those who are listening and watching from home. Special thanks to Dr. Wright for this wonderful opportunity. It's a dream come true for me to be here in this facility, in this community, I should say. And hopefully the information we provide today will be helpful as you take care of yourselves, because this is a complaint that we see a lot. So hopefully you learn some things. So we're going to go ahead and get started. Dizziness, as you all know, is something that is common. Take it off the stand? Okay. Actually, that's okay. I just have to, okay. It's not too tall a person, okay. Dizziness, as you all know, is something that at one time or another we're going to feel, but it's something to learn more about because it's a very important problem to know more about. So today what we're going to talk about is just the basic definition of what is dizziness, to have a better understanding of what it is. We're going to talk about some numbers that concern the senior population when it comes to this particular complaint, and we're going to talk about the risks that are associated with this particular issue. Also, what causes it, and what we should do, and what to expect when we're being treated by a doctor when we go to consult with this problem. So what exactly is dizziness? And why does it occur? So what do you all feel when you look at this picture? It makes me dizzy. So I got that out of Wikipedia. And the definition in Wikipedia for dizziness is a sense of disorientation in space, vertigo, lightheadedness, or disequilibrium, which is exactly what this picture makes me feel. The other thing about dizziness that I would like you to know today is that it's a very common but non-specific complaint. So when you complain of dizziness, you might think you're being specific, but to the doctor, that is way too general. There are some people who have it constantly. There are some people who have dizziness all the time. There are some that are going to have it intermittently, and there are some people who will have it frequently. And then another thing I want you to know today is that dizziness is usually something that is caused by multiple things. So you can't just hear that somebody's dizzy and think, well, it must be one thing. Maybe they didn't drink enough water. So we say it is multifactorial in cause. When we see folks that come to the hospital complain about dizziness, some of the words they would use is that I have a sense that I'm going to faint eventually. I feel woozy. I feel unsteady. I feel lightheaded. I feel heavy-headed. Some numbers that I think we should know is that in seniors, up to 38% of them in some studies have dizziness. There's a study that found that 44% of patients who were studied were between the ages of 65 to 95. So I thank Dr. Wright for picking this topic. It does concern us. And also that, 44% of people had more than one condition that caused dizziness. And also medications were a contributing factor in 20 to 25% of the seniors who had this complaint. So you see where the medications you take may be related to your dizziness. That may not be the only reason, but it's something to keep in mind. So I urge you that when you go to see your doctor, always have a list of the medications you're taking, because the list they have may not be correct. You're the one who's probably going to have the most correct list, and it's important that somebody looks at that list. When it comes to balance, so I'm able to stand on stage here, and if you notice, I'm not falling, I'm not acting like I'm going to fall, because there are multiple things that are playing a role in why I'm able to be confident in my standing up here. One is my eyes. So my eyes basically tell me what's going on around me, where I'm moving to. I can see left, I can see right. I know exactly if I tilt my head, I know that I've tilted my head, I can see. If you have vision problems, that might affect that balance. So that's why it's important to get your eyes checked. If you have cataracts, get somebody to work on that, because it's playing a role in your balance. Very important. The inner ear, a lot of people don't give the inner ear much credit, because when you look at the ear from the outside, it just looks like a small part of the body. But inside, there's a complex system which helps us sense gravity, rotation, back and forth motion. So imagine that something's going on in your inner ear. Would that affect your balance? Yes. Another thing is sensory nerves. Nerves are so small, we don't see them. We hear about nerves, but it's a complex network, and Dr. Vasovagal is going to show you some pictures where you can see how the nervous system is. And the peripheral nerves, that senses, external stimuli, is very, very much a key player in a person's balance. So dizziness is one very vague complaint, but involves multiple parts of our body, is what I'm trying to express. What causes dizziness? So vertigo is one that is common. A lot of people who have vertigo would tell you that when they make head movements, it makes it worse. Sometimes they'll tell you that they feel like they're tilting. They feel like things are spinning. Either they're spinning or the room is spinning. Another type is pre-syncope, which Dr. Vasovagal is going to expand on. This is where somebody would say, I feel like I'm going to faint. They don't actually faint, but they have this feeling that they are going to faint, which you can imagine is very frustrating because no one wants to feel like they're going to faint. You just feel hopeless, like nothing can help at that time. Some people would tell you that when they are upright, they feel dizzy. And then people who have heart problems usually would fall in this category of pre-syncopy, and Dr. Vasovagal will expand. Disequilibrium, of course, is just a sense of imbalance. So like I said, me standing up here, I feel very well balanced. Even if I stood on just one leg, I still feel well balanced. If I have problems with peripheral neuropathy, that could affect my balance. If I had Parkinson's or Parkinsonism, that could affect my balance, as well as certain conditions going on in my brain or in my cervical spinal cord. The most talked about type of vertigo, we call it Bppv. There are several people that I've seen, even in this facility, who have this condition. It's benign proximal positional vertigo is the word, but we just abbreviated Bppv. This is where sudden, brief, and severe, somebody has the sudden, brief, and severe sense that they're spinning or moving, and it's usually triggered by a change in their head position. The reason why I want us to talk about this is because this is one of those conditions that physical therapists and doctors work together to help patients with this problem. And the issue here is that you've got these little particles in the inner ear. They call them otoconia, and they float into the wrong part of the inner ear. They're not supposed to go there. So people who don't have this problem have no issues with these little stones migrating. But folks with this problem, those little stones have floated away and they're in the wrong part of the inner ear, and they're giving confusing messages to the brain about movement. So what doctors do is, first of all, when you go in for an appointment, they will do some maneuvers to try to figure out if you have this problem. And then if they determine that this is a problem that you have, they will prescribe this a procedure, which is called a Canalith repositioning procedure. You can see there in the picture, you see how complex that inner ear is with the different parts in that picture up top. And then you can see the different positions that the doctor or the therapist will put the patient in to try to move those little granules to the right place. And there are times where people have to go back several times to get this fixed. For the most part, you could get it fixed the first time, but then if the symptoms reoccur, you can go back and get the procedure done. But this is kind of a good way to resolve that problem. So if you have Bppv, you've most likely experienced this particular procedure. I like it because it's not an invasive procedure. You're dealing with a very delicate part of the inner ear, but you're just doing manipulations and it's not invasive. What are some of the medical conditions that lead to dizziness? Remember, we said dizziness is something that is very, very broad, but you could have people with what we call vestibular migraines. We could have people with anxiety disorders or panic attacks that experience dizziness. People who have had head trauma. So even after like a motor vehicle accident or a fall, you could experience dizziness. Medications, I talked about as really important. That's why when you go in to see the doctor, take your lists, because there might be something on your list that is not on their list that may be causing the dizziness. So it's important that they can look at your medications and try to figure out what is causing it. Also, hypotension, when you don't drink enough fluids, or for some reason you're losing fluids, having issues with the volume that you have in your circulatory system could cause dizziness. People who have had a heart attack could tell us that one of the symptoms that they're having is dizziness. Also, people who have problems with the rhythm in their hearts. And we'll talk later as to the tests that are going to be done in the hospital when you go. One of those tests is an EKG to see if your heart has the normal electrical activity that it should have. And then also there are some people who just persistently have, dizziness. And that is just a diagnosis that they carry for a long time. The risks, especially when we're talking about seniors, falls, we all know how dangerous falls are. So dizziness is an important thing to know about and know what to do when you have it, because it could lead to a fall. And that, we all know what happens when we have a fall. Many other things could occur after that. We could get injured, we may need surgery. So that's why I'm urging you that if you have dizziness, you do need to report it to somebody. You do need to seek medical attention so we can find the underlying cause of your dizziness and handle it before we get to a point where we're falling. Also, if someone is dizzy and they're not able to have their normal function, it can affect their exercise. It can affect their social activities, their ability to socialize. So we all know that when we wake up every day, we have a list of things we got to do. Maybe we're going to go gardening. Maybe we're going to go to the grocery store. Maybe family is coming to visit. Well, if you're so dizzy that you're not able to do those things, where are you going to end up? You'll find yourself in bed, because that's the position that is more comfortable for you. Because if you sit up, you'll feel dizzy. Maybe if you try to stand, you're afraid of falling. So it is a problem. Also, consequences, if we fall and we end up with a fracture that changes our entire functional status, we may see ourselves moving to a different level of care. So it is a serious issue because, we want to be as independent as possible and take care of ourselves and be functional. Also, dizziness could lead to loss of life, unfortunately, because if it occurs, and we don't find the original cause and treat it, that may be it. We may not be able to fix things anymore. So it is a very serious topic. So what do we do? One of the things that I would really like to leave with you after this talk is you have to take responsibility as a patient, somebody who has dizziness or who may end up having dizziness. You have to know what your role is, because it's a partnership between you and the medical provider. So one of the things that I want all of us to keep in mind is if your dizziness is severe, if it's sudden, if it's prolonged, if it keeps happening, please come see us. You've got to tell somebody. This is not something to keep to yourself and say, well, it'll go away, because we could end up with a fall. We could end up with a more life-threatening condition that we didn't take care of. So please, first thing is tell somebody, seek attention. And another thing I want you to do is, because dizziness is such a broad topic for the doctor, it's caused by so many different things and could be a symptom of so many different things. One of the challenges, especially in the doctor's office or in the ER, is gathering information from the person who has experienced dizziness. So one of the things I want you folks to do is, if you experience dizziness or if you talk to someone who's experiencing dizziness, tell them to write down what is happening when they're experiencing it after they've settled down. So let's say you get up in the morning, you experience dizziness for a period of time, and then you feel normal again. Just grab a pen and a paper, write down how you felt. Was the room spinning? Did I feel like I was tilting? Did it happen suddenly after I stood up or after I sat up? These are all the things that the doctor is going to ask you. So if you take notes and keep a little journal, when you finally present to the doctor, it will make it easier for the doctor to put you in the two categories that we normally would put patients, which is pre-syncope or vertigo. So that will be very helpful. The reason why I think it's important to gather information about dizziness when you experience it is that in the case that you show up in an emergency room or an urgent care, that doctor is worried about some big problems. There are like 4 big problems that they're trying to make sure that they don't miss. And those problems are grouped based on what you tell them you experienced with your dizziness. So if you say, I was dizzy, then I had a headache and my neck hurts, they want to rule out something called a subarachnoid hemorrhage, which some of you have probably heard about. It's a serious condition, and you having the right words to describe what happened to you will help the doctor to work that up. Another thing is if you say, I had dizziness and then I had chest pain and then I also had shortness of breath, they're thinking more about the heart or that you may have a clot in your lungs. So you see where you're helping the doctor to help you. If you say dizziness and palpitations, definitely they want to pay attention to the EKG to see what's going on with your heart. Is your heart rhythm normal, or is there a change in the rhythm that the cardiologist needs to be paying attention to? Also, if you have you have dizziness and some other things that have changed in your nervous system, like problems swallowing, just some little symptoms that may not be important, you don't think may be important, that doctor may be looking for the neurologist to try and get involved. So that's why I'm urging you to have a journal, write down all of the things surrounding your dizziness. Were you sweaty? Were you shaky? Did you fall? Did you feel like you were going to fall? Were things spinning? Were things tilting? Did you have problems with your vision? Very important to help that doctor who's going to be seeing you first. When you also write your notes about your experience, if you should experience dizziness or if you're talking to someone who may report to you that they've had dizziness, also write down how long it lasted to the best of your estimate. Nobody really sits there and times their dizziness, but just a general idea. This lasted all morning. This lasted maybe 30 minutes. Also the timing. Right when I woke up this morning is what somebody told me the other day. Right when I woke up, as soon as I sat up, I felt dizzy. Or when I got up to go to the bathroom at night, as soon as I jumped out of bed, I felt dizzy. Also, the things that triggered it. When I was in the upright position, I felt dizzy, but when I did lie down, it was gone. Or when I was walking. Also, medications. Yes, we may have your list of medications, but maybe you went to a different doctor who changed the dose. We would like to know. For example, maybe your dose of your water pill got changed. We would like to know, because that could be what is causing the problem. Or your blood pressure medicine. Maybe you went to an urgent care, they changed it. We would like to know. Once you are like in the ER or urgent care setting, don't be surprised that some heavy duty tests are done. I've seen people who say, well, I'm just a little bit dizzy. Why are they doing all these tests? Well, from the talk we're having now, you know that there are some big problems that dizziness could be an indication of. So we're definitely going to check all of your vital signs, your blood pressure. Sometimes even we'll check your blood pressure while you're laying flat, when you sit up and when you stand up. This is the reason why. Also, we're going to do, most likely do a blood test. We're going to do your blood glucose check to see whether your blood glucose is within normal. And then the EKG we talked about to check your heart rhythm. And then an MRI, don't be surprised, because in the case of a stroke, that is the best test to show if somebody has had a stroke. There are certain strokes that you can't really see with a CT, but you could also have a CT and something called a CT angiogram, where they're going to put some dye in there to have a better vision of certain vessels in the brain. So don't be surprised that you went in with a simple complaint, what you thought was a simple complaint called dizziness, and then you ended up getting a full workup. Now you understand the reasons. In the case of pre-syncope, I'm going to have Dr. Vasovagal expand more about that when he's ready. Thank you very much.
So I just wanted to say thank you, Dr. Andela, for giving an overview and really talking about what to expect, what to note, and this topic about dizziness, which can be serious and it really does deserve medical attention. You know, I wanted to go over the different types of dizziness, and like Dr. Andela said, dizziness is a very broad category. It's not specific, and we actually categorize dizziness into different categories. So Dr. Andela mentioned vertigo, which is one of the categories, the sensation of the room spinning or the environment spinning around you. If you describe that, we have a different mind frame about what we're thinking could be causing it. If you mention something related to lightheadedness, feeling nausea, flushing, we may think of what's known as pre-syncope. So pre-syncope is the sensation of near fainting, lightheadedness, and it's important to note that it doesn't involve loss of consciousness. So these are some of the other symptoms as well. It can include feelings of warmth, sweating, changes in your vision, and it's caused by a low blood flow to your brain. And there's even several different types of pre-syncope that I wanted to touch on. So some of the causes here of pre-syncope, one of them is reflex pre-syncope. So this has to do with your autonomic nervous system, which is a part of your nervous system that regulates your bodily functions without even you thinking about it. For example, if it is very bright outside, your pupils will shrink because they don't need to bring in as much light. So alterations in this can cause reflex syncope. It's often known as your fight or flight response. So this slide is pretty busy. I wanted to show it because it gives you an idea of just how complex some of these mechanisms can be. It involves several nerves. It involves several organs. And it involves so many things that you never think about. Your heartbeat going up, your respiratory rate going up, stimulating certain chemicals in your body after you eat. So this is all part of your autonomic nervous system, the part of the nervous system that just acts automatically. But alterations in this can cause that symptom of lightheadedness that I was mentioning. So the other type of reflex pre-syncope is vasovagal. So this type of pre-syncope, this lightheadedness, involves triggers that could include emotional stress, fear, prolonged standing, and like Dr. Andela was saying, all of these signs and symptoms of dizziness can be associated with other forms of dizziness. And it involves that complex autonomic system of things not working exactly as they should, and ultimately it leading to low blood flow to your brain, which causes those symptoms. And then situational pre-syncope is similar to that. It involves the pre-syncope, the lightheadedness, brought on by certain actions such as coughing, swallowing, defecating, these sorts of things. So if there's one slide that I wanted to really highlight and for you guys to pay attention to, it would be this next one here. So this is very common in older adults, orthostatic hypotension. It's a broad category that it can involve a lot of different things, but basically it involves just a significant reduction in blood pressure when you stand from lying or sitting. So it mentions there the underlying mechanisms involving that autonomic nervous system or volume depletion. Medications can also cause this. So volume depletion, it's really important to stay hydrated. So for most patients, 1.5 to 2 quarts of non-caffeinated and non-alcoholic fluid per day. And if you've seen Dr. Wright, I'm sure you've heard, because he's great at just spreading this message, sometimes we lose that sense of thirst. So it's important even to drink when we're not thirsty sometimes to make sure that we stay well hydrated. Because when we're lying down or sitting and then we stand up, there's a rapid sequence of events that occurs in your body. So right when you, from the upright position, there's 500 to a liter of blood in the lower extremities, which then is pulled into your veins and returns to your heart. That means there's, in that moment, less blood in your heart, reducing how much blood is pushed out, and it also reduces blood pressure there. So that fall in blood pressure involves that autonomic nervous system to have a series of reflexes go off to constrict your vessels and then increase your blood pressure. So these are all the compensatory mechanisms going on, and in older adults, those reflexes can become diminished. So this can be a very important cause of lightheadedness in patients. So, and I did want to mention real quick, when we do diagnose orthostatic hypotension, the way we diagnose it is measuring your blood pressure in different situations, and depending on how much that blood pressure falls from lying to sitting, we can classify that as orthostatic hypotension. So another cause of pre-syncope is arrhythmias. So these are those abnormal heart rhythms. AFib is a very type of abnormal heart rhythm, but just to note, it rarely causes pre-syncope. A lot of the times, it can be other types of arrhythmia. So if you do feel like you need to faint, it is important to seek medical attention. And of course, we will monitor your heart either with an EKG or possibly a longer-term device. And then, of course, treating the underlying cause can help prevent this. And depending on the type of arrhythmia it is, you may undergo different procedures, including an ablation or even a cardiac device. An ablation involves zapping parts of your hearts to reduce the electrical connectivity that shouldn't be there. And then a cardiac device like a pacemaker keeps up your heart rate, and it helps regulate your heart rhythm. And then finally, the last cause of pre-syncope here can be structural cardiopulmonary disease. So these are your things like coronary artery disease with or without a heart attack. It could involve the valves of your heart being damaged. And then the treatment for this is usually surgery, and we diagnose these sorts of things a lot of times with an echocardiogram or possibly heart caths if you had them before. And then I do want to just take a minute to really differentiate between syncope and pre-syncope. So pre-syncope, like we talked about, you never actually lose consciousness. It's the feeling of lightheadedness, feeling faint. Syncope is when a person does actually lose consciousness. They usually spontaneously recur. It doesn't last long, but I do want to differentiate these two because basically the same things can cause either one of them. And then another cause of dizziness is disequilibrium. So this is that sense of imbalance that occurs primarily when walking. So the causes of disequilibrium, Dr. Andela touched on some of them as well. Peripheral neuropathy, a disorder with your muscles, something in your inner ear, in your brain, parts of your brain can cause this, your cervical spine, Parkinson's can cause disequilibrium. And as well to note, it's very common for people with Parkinson's to also have orthostatic hypotension. So because it does affect the autonomic nervous system. So like we were saying, a lot of these things can be mixed. It's usually not just one thing or the other. And then all of these can lead to a fall, which is just a huge setback. It can really change things. It can really drastically alter the course that you were on. So really important, if need be, if recommended, to use a walker when need be. It may not be for some. I think they don't look too bad. I mean, with the four wheels and have some support, but it will help you keep your balance and prevent those types of falls. And like we talked about before, these are just some of the workup that you may get: imaging, blood work, heart monitoring. So there's a lot of types of tests that we can do to help diagnose the different types of dizziness. And just to reiterate the different types of dizziness here, we talked about pre-syncope, that feeling of lightheadedness, feeling like you're going to faint. The disequilibrium, the imbalance when you're walking, not feeling steady. Vertigo, feeling that the room is spinning or that you're spinning. And then there's just some other non-specific types of dizziness and mixed disorders, but I think I hope that we made it clear a little bit about how we categorize dizziness, what are some of the symptoms of each different type, and what to look out for, and then also what to expect if you do develop dizziness. So, thank you. I'll ask Dr. Andela and also Charles if there were any questions.
Yeah, we really do encourage you to ask any questions. I think usually the questions and answers are where we impart most information. So then we find out what you really want to know. Yes, ma'am.
Hello. So the reason why I skipped over that, it's a complex test that is done by the doctor. And it has multiple steps. So she's asking about the HINTS test being one of the things you should expect if you showed up, for example, in an emergency room with a complaint of dizziness. We told you folks you're going to have your orthostatic vitals, you're going to have an EKG, but one of the things that a doctor is also going to do is a HINTS test. The reason why I put it up there is just so you hear the word for the, but just know it's a series of medical tests done by a doctor, which is very complex. It's going to take time. I just wanted you folks to kind of have seen it before, but it's not really something we want to get into because it's pretty detailed. But if the doctor says, we're doing something called a HINTS test, at least you know that it has to do with the workup for dizziness. Thank you for asking.
We talked a little bit about the ear, and most of us here have someone who's wearing something with their ear blocked, ear plugs or something that they need. And I wonder how much that affects our busyness. And the second thing is, when I was working with my mother, I talked to a doctor there, and he said he was absolutely shocked that most of the people he saw from nursing homes and retirement homes had not had their ears cleaned for years. And he said they would come in and say they were partly deaf. And he said, I couldn't believe. So it seems to me that would be one question a doctor would look in the ear, and if it was completely blocked, that might be one of the ideas for the dizziness.
Well, my only comment about that is I do think you're exactly right. I think a lot of people don't have their ears checked, or physician fails to inquire about that. But it rarely has anything to do with dizziness. It's certainly hearing, but typically not involved with dizziness.
Please ask.
It's a very intelligent audience.
Yes.
Some of the questions are almost too difficult to answer.
I just learned about vertigo by having it, but I just want to say that our physical therapist here is absolutely wonderful, and I don't have it anymore, thanks to him.
A lot of physical therapists become trained in, the formal term is vestibular rehab, but it's this series of treatments that she depicted here on one of these slides, where it's a repositioning that trains those little granules into a spot that won't cause the vertigo. But it's very effective usually if the diagnosis is that benign paroxysmal positional vertigo. You know, vertigo is such a difference. Listen, if you've not had vertigo, I bet some of you in here have. It's fairly common, but if the first time they have a bout of vertigo, if it's other than just very mild, it's so disorienting, it's so frightening. They think they're having a stroke, and for understandable reasons. The room is spinning around and everything's out of control, and you thought you were drunk? I have heard people say it was just like when I was in college and I hung over.
Well, as you know, Doctor, I fell and hit my head and got vertigo, but that was easy to take care of. You took care of it very quickly, but beyond that, I still had dizziness, and you sent me to the physical therapist, and he gave me a series of exercises I had to complete, and I'm going on my 6th month now. I'm finishing up my 6th month, and everyone told me it would take a long time, but I'm just now, I can really feel like I'm over the hill. I'm well enough now that I don't worry about falling, but I was so dizzy and out of balance, and it's taken 6 months for it to clear up. Does that sound normal to take that long?
Well, you know, I'm not sure who can say what normal is for that kind of vertigo, the kind you had from trauma. I'll tell you, we see very few people who get vertigo because of trauma. It certainly happens. In your case was certainly one that did. So most everybody's experience with how well does the rehab work is from non-traumatic vertigo. And the non-traumatic type of vertigo usually responds, within a few sessions, but it's not ongoing for 6 months. So I think you're pretty exceptional that way. But, I'll put in a plug for Dan. Most of you know Dan in physical therapy here. He's very talented. I think he's a very good therapist generally, but he's certified in the Epley maneuver and this vestibular rehab. Then I found out what his ace in the hole is, and that is his sister specializes in this at Mayo Clinic. So if he gets a difficult case, he didn't tell you. He goes over there and says, "Oh, listen, sis, I've got a tough case here." Not really, but I think they do discuss it a lot, and I think that's. But he's really good at it. I've been pleased with his outcomes.
I'm puzzled how physical therapy relates to your brain and dizziness. What do they do in a few words, if you can tell us?
Yeah, I could. So, yes, it is weird because physical therapy, we're thinking of other things. And like we talked about, the inner ear is quite complex. It's got several, if you remember the picture that I put up,
I think it's slide number 11.
we'll have him.
Nathan, can you go back to 11?
So while they're getting that up there, there you go. So if you see the top picture, if you look to the right, you see those are called semicircular canals. And you see the little otoconia, the little granules in the picture on the right. They're like little dots, but those are actually granules. They have to sit in a particular part of the canal. In people who don't have that problem, they're sitting in the right place. But for some people, they float and travel to the wrong place. So what the therapist is doing is making movements to transfer them back.
So they're moving the head, and with your head hanging off the table, and there are 4 steps there. And even in the last step, her head is in 2 places because it's showing how it's turned. You have to know exactly how to do that. Now, a person can be trained to do it on themselves, but that's what a therapist does. And so it's not typical type of physical therapy. It's this kind of, this vestibular therapy is about manipulating this so that in every different plane, it lets the gravel in there sort out to another place, and finally, after 3 turns, it should be collected in a place where it's not going to interfere with your balance and your equilibrium.
So he doesn't really know where it is.
Well, he isn't looking at it. He can't see it while he's doing it, but they collect in the typical place out in those circles, and you need to get it back where it's out of those. It's partly a degenerative deposition of granules that shouldn't be in there. So it's one of these things that happens more likely with age. Darn it.
That was a great question. Thank you. More questions?
That's the classic vertigo Epley maneuver treatment, Epley. But what I had was way beyond that. It was a balance and dizziness problem that only helped by a bunch of silly, crazy things he asked me to do. I was embarrassed walking up and down the hall, turning my head side to side for movement and up and down for movement and sideways.
I guess he could tell in your case that it wasn't just.
It wasn't that, no.
Collecting in the same usual place. Oh, really?
This is mainly for, just to clarify, Bppv. That's that condition that was discussed before, the Canalith repositioning. There's other types of vestibular physical therapy to go through depending on what the cause of the vertigo could be.
Yes. The Epley maneuver worked very quickly on me. I got rid of that pictures going around the room spinning. But it's been 6 weeks on the other thing, which is much more disturbing than this, and that is loss of balance and dizziness, which you have to do a series of, as you called the word, weird maneuvers.
from now on. You know, if I had a period when it bothered me, to just do those. She gave me the exercises to do. Yeah. Yeah. Well, I don't get dizzy standing up, but sometimes if I get up and go to the bathroom at night and I come back to bed and lie down and whoa, it'll spin for a little bit.
Yeah, usually this postural dizziness, the orthostatic hypotension that Rico was talking about, that's usually not a trigger for vertigo, but it is for other important kinds of dizziness. And but so it rarely is anything much to do with vertigo. Sometimes it does, not much.
Do you think water aerobics, where you're in the water jumping up and down and just doing things you don't do out on the ground, would that stave it off maybe? Keep it stirred up, keep those granules.
I can't think of anything. When I looked at treatments for different vertigo, I didn't necessarily see that preventing vertigo, keeping it stirred up like that. It is very specific head maneuvers that help reposition, especially in this case of Bppv, reposition those granules.
But it's good for so many other things.
Yeah.
Especially arthritis.
Gosh, it's so good to see you guys face to face again. You've always been so supportive of these, and I do appreciate it. It's good to get out again, isn't it? Well, I think many of you've heard me say it. Many of you have heard me say it. I'm so impressed and so proud of Butterfield Trail Village. I'm really talking about the people in this room and so many others on this campus who live here signing up for the vaccine. I don't want to say anything bad about people that don't take the vaccine, but on the other hand, I don't understand it, and I think it's so important to have taken it. And I don't know of any kind of organization, any sort of campus or facility that can boast of 99% sign up for vaccine. And y'all proved you believe in science.
Yep.
I've only this year become aware of how many people apparently don't believe in science. But I won't go off there. But anyway, thanks for that. I think it makes such a big difference. And by the way, the fact that we're still wearing masks is because, we've discovered that masks are political. We've also discovered they're bureaucratic. And since we work for an organization that has its rules, our rules are that we keep doing this for now, even though every one of us have been vaccinated. I'm glad all of you have been vaccinated too. So I don't think there's any chance we're going to be transmitting it among this group, but we've got our rules. Bureaucracy. Thanks so much for coming. So appreciate it.
Thank you.